Good day, my colleagues, the candidates for the MRCS Part B examination. I'm so grateful to meet you today, and today we are going to discuss a new station in the critical care. And actually, it is a straightforward station, but actually, it needs some skills. So, you want to know about how to read the X-rays. And this station actually we can give it the name of a pneumothorax, and actually you are going to be asked some questions about central venous line insertion. So let us go to the questions. First of all, they are going to bring you an X-ray, and this X-ray actually is going to have a black side. Okay, one of the sides, chest X-ray, and one of the sides of the chest is completely black. Okay, and they are going to ask you about first of all, how do you read an X-ray? And to make it easy for you, if you want to read an X-ray, you want to follow the ABCDEFGH system, so you can remember. Okay. So in the X-ray, chest X-ray, especially chest X-ray, you are going to check the airway. Is it central or not? We are speaking about trachea and the main bronchi here. Then after that, you are going to check the B, and the B you are going to speak about the situation of the bones here, and they are going to give you also an idea about the quality and the symmetry of that X-ray. C, you are going to look for the cardiac shadow. If is it enlarged, is it within normal range? Okay, so you are going to go to D, and D you are going to check for the diaphragm, because the diaphragm should be apparent for you in the X-ray as the costophrenic angles. Okay, you are going to go to the E and F. Both of them are pointing to the equality of the lungs fields in the X-ray. And you are going to go to the G. You should see the gastric bubble as long as the costophrenic angles are there and the diaphragm is there, so you are going to see the gastric bubble. And finally, you are going to check the hilum and the mediastinum, the hila of the lungs and the mediastinum. So this is the system by which you are going to read an X-ray. They are going to ask you about that frankly. Okay. So next question, they are going to ask you, what is your diagnosis in this X-ray? You are going to mention that this is a pneumothorax. Okay, black discoloration of one side of the chest in the X-ray. So they are going to ask you the next question, what is the difference between tension and simple pneumothorax? And what is the difference between primary and secondary pneumothorax? So let us start with the difference between simple and tension pneumothorax. Okay. So in tension pneumothorax in general, okay, because in tension from the name there is tension, there is pressure inside at this side. Okay, so there will be some sort of shifting of the mediastinum and trachea to the opposite side. This is number one. Number two, in the vital signs there will be tachycardia and there will be maybe severe hypoxia. Okay. Number three, you want to mention that this is an emergency. Tension pneumothorax is an emergency. And to treat this emergency, you want to insert a needle, something called needle thoracotomy. You know that there are many types of thoracotomy. There is tube thoracotomy, there is needle thoracotomy, there is open thoracotomy. It depends on what you need. So you're going to insert a needle and making what's called needle thoracotomy in the second intercostal space, the mid-clavicular line. Okay. Then later on, after you release this tension, you are going to make a tube thoracotomy, inserting a tube so that underwater seal, and you are going to make this at the 15th intercostal space, okay, the mid-axillary line, or just anterior to the mid-axillary line, okay. Usually in the tension pneumothorax, you want to mention that there is the opening which caused this. It is usually due to trauma, actually. So the valve or the lesion which caused this problem usually, it allows the air to enter inside, but it doesn't allow it to go to the outside. That is why tension develops. So you want to mention this also, that you have the wound or whatever the source of the tension is, that the reason is that it forms a one-way valve, okay? Well, simple pneumothorax, actually all these things are not there. Person may be stable, there is no problem, okay? It may occur due to any other reason, maybe some lesion that ruptured in the lung, for example, or whatsoever, okay? And if it is open and the air is going and coming back, it's okay, there will be no problem. It is not comfortable and the patient is not normal, but it is not an emergency, okay? But you want to treat it. So it is, for you as a surgeon, this is not your issue, it is a medical issue. So they are going to ask you, you mentioned that you are going at the end to make tube thoracotomy. You are going to insert a chest tube. So they are going to ask you about the safe borders or the safe area, or they call it the safe triangle for insertion of a chest tube. So you are going to mention as follows. Anteriorly, you should have the lateral border of the pectoralis major. Posteriorly, you will have the mid-axillary line, because it should be just anterior to the mid-axillary line. And inferiorly, you are going to have a line that is drawn from the nipple backwards. Okay, so you know the nipple is at the level of in the male is at the level of the 5th intercostal space. So you understand this already. So they are going to ask you what are the indications for, now they are going to shift to, we finished from the pneumothorax for now, they are going to shift to the insertion of a central IV line. Okay, so what are the indications for insertion of a central line? And there are actually 6 main indications for insertion of a line. Okay, the first indication is for monitoring for fluid balance, especially if there is no vein outside in the critical care situation, because this is the critical care status or critical care station, and fluid resuscitation. All these actually are indications. Another indication is total parenteral nutrition, TPN. Okay. The third indication that there are some certain fluids and medications that are not being given peripherally, like for example the potassium-rich fluids cannot be given by peripheral vein, and in this case you are going to use a central vein. Okay. Fourth, if you failed to find a peripheral venous access, you are going to make a central line. Okay. It is used for hemodialysis also, and for transvenous cardiac pacing you need also a central access. Okay. They are going to ask you what are the complications of central venous line insertion. You want to mention, actually there are about 7 complications almost. Okay, so number 1, as usual, infection may happen because you are inserting a sterile area, so infection and thrombosis also is a possibility. Air embolism may ensue. You may puncture the artery by mistake, so this may lead to a severe fatal hemorrhage. Pseudoaneurysm may happen in the future, and hemothorax may occur in this situation, especially if the central line is in the neck. Fourthly, pneumothorax may develop actually. Okay, you may cannulate the left internal jugular vein, for example. You may choose that side, and if you choose it, you want to know that the thoracic duct is around. And if you rupture or injure the thoracic duct, you are going to cause what is called chylothorax. So the lymph is going to fill the thoracic space. Sixth, your catheter may rupture the right atrium, and in this case here, you are going to cause a cardiac tamponade. And by the way, arrhythmias may happen. Okay. So they are going to ask you a straightforward question. What are the NICE guidelines for central venous line insertion? So number one, this is very important actually. Number one, insertion should be under ultrasound guidance. This is number one. Okay. So after the procedure, you want to make a radiograph. So they will ask you, why do you make a radiograph? There are some reasons. Number one, you want to know the position of your line in the superior vena cava if you are inserting from the neck. It should be superior, okay, and at the entry of the right atrium. And you make an X-ray also, chest X-ray, to check if you caused a pneumothorax or not. So they will ask you, what is the technique for insertion of the central venous line? So number one, you want to know the anatomical landmarks. Okay. You want to know where is the sternocleidomastoid muscle, starting from the mastoid process to its insertion at the clavicle. You want to check the carotid pulse, and you want to check it actually in an area between the two heads of the sternocleidomastoid, the two heads of insertion of the sternocleidomastoid, okay, or origin anyway in the clavicle. So the triangle is made by the clavicle and the two heads of the sternocleidomastoid. Here at this point you want to check the pulse of the carotid artery. Okay, so you located your landmarks now, and at the center of the triangle, and by the marks you have mentioned already, you want to palpate the artery, and you want to insert your needle lateral to the artery, lateral, away from your body. Okay, so how do you insert the needle? Your needle should be inserted 30 angles toward the patient, toward you or the patient, in the coronal plane, aiming toward the ipsilateral nipple. Okay, so your angle of insertion is 30 degrees. You are inserting here according to the coronal plane, and you are moving toward the ipsilateral nipple if you are making to the right or making to the left. Okay, so next, you inserted already. Now you are going to aspirate as the needle advises, so you will know if you are going right in the vessel or outside to the lungs, which can cause to the chest space, to the thorax, which may cause pneumothorax. And then after that, you are going to cannulate it by Seldinger technique. And after that, you are going to suture the line in place. So in case that they ask you about the Seldinger technique, Seldinger technique is very easy. Actually, you are going to insert this needle, which we are talking about now, and you are going to bring your line, your tube over it, okay, over the needle, and insert it inside and put it in the place you want to put, because it is under ultrasound guidance, and you are going to take your needle out and then you suture your tube. Okay, so what are the removal techniques regarding the central line? If you want to remove the central line in the neck, you want to put the head down. So in this way, you are going to prevent air embolism. Okay, you know that air embolism is one of the fatal conditions, especially if it is related to the heart, right? So Now we spoke about the insertion of central line in the neck or in the carotid vein. Okay, so give examples for the sites where you can insert a line. So you have the internal jugular vein. You want on the left to take care of the thoracic duct. The subclavian vein is an option. The femoral vein is an option. Okay, and sometimes you insert it peripherally from the peripheral vein, and you take it all the way to the central area, which is not usually used. Okay, so they are going to ask you that this central line that you have inserted caused an infection. There is an infection at the site of insertion. What is the causing organism? And here most of the people make the mistake of mentioning Staphylococcus aureus. Here in this case it is Staphylococcus epidermidis. Okay, and actually this is a fatal mistake. Okay, because it will mention how are you going to treat the infection. So how can you prevent the infection in your line, in your central line? These are ABCs, all of you know it, but you want to star on it, so you want to mention it in a good way that will be attractive for the examiner. So number one, you want to perform hand hygiene. You know hand hygiene, the 7 moves and these things. Okay, you want to apply the appropriate skin antiseptic for the patient, because skin is not that clean, right? You want to ensure that the skin is well prepared with an agent that is completely dried before you insert your central line. So you apply your agent on the skin and you wait till it dries. Then after that you start your process. You want to use all the 5 sterile barriers. And what are those? Number 1, you want to use sterile gloves. Number 2, you want to use sterile gown. You want to use a cap. You want to use a mask. And you want to use a large sterile drape. Okay? Well, then once the central line is in place, you want to take care of it so no infection will happen. You want to follow the protocol for the maintenance. Okay, and you want to wash your hands every time with soap and water or alcohol based whatsoever, okay, before you touch the line. Okay, then the important point here, actually, whenever you feel that you do not need the line, you want to remove it. Okay, so the sooner you remove it, the less likely the infection is going to happen. So this is the station. It's an easy station. It is an ABC station, straightforward, and I'm sure that you are going to do perfect in this station. So see you next in another topic and another station for the MRCS Part B.